Um, it's very hard to follow on from the Noble Lord Moylan and Lord Carlisle, and contributions given with such panache and wit and insight. What really intimidated me was when the Noble Lord Moylan said, this amendment is all about understanding the mathematics. And I thought, oh God, I put my name to it. There's been a terrible error. I bring absolutely no mathematical understanding whatsoever to the question. But the reason why I put my name to it, and the requirement the medical practitioners should discuss underlying data on survival in terms of the median prognosis of 6 months and how it's calculated and so on, was because I'm very interested in ensuring, in relation to this bill, that there's maximum transparency for patients to ensure that any choice they make is well informed. And the bill rightly requires that an applicant for assisted dying is informed, and it seems obvious, therefore, that being informed should include an understanding of the context of the data and reliability of prognosis. That would help you in terms of informing yourself. If we accept the bill's criteria of terminal illness with 6 months to live, and despite what the noble lady Baroness Hayter said, I mean, I don't think you can see it with your eyes. That will do. There's no. I mean, at the moment I've got a terrible cough and cold, and if you look with my eyes, I look like death warmed up, right? I mean, I don't think that's good enough. I'm hoping it's a bad way of judging one's longevity, as it goes, right? But there is some basis on which a prognosis is made. They can see the tumours, they know you've got an illness, they're making a point, right? But anyway, the point is that prognosis based on median life expectancy, despite that, is highly uncertain. And it's only right that applicants should be informed about the limitations and underlying data behind such estimates and their uncertainty. As anyone here who has faced a terminal diagnosis will know, and it does seem that many have and live to tell the tale, or many of my noble lords will know from friends and family, when you're told the condition is incurable, the first thing you ask, that a patient asks, is how long? It's actually hard to get an answer out of a doctor precisely, usually. The patient wants to know how long because they want to know the worst, they want to know in order to arrange their affairs, financial or personal. They want to work out how to spend their end of lifetime and so on. The doctors can be eventually cajoled into giving a timescale, often reluctantly. When they do, it's usually to help a patient to organise their affairs, sometimes in giving them a timescale in order that they can benefit from access to benefits or get care support or anything. And I'm concerned that this bill will encourage a sense of 6-month certainty, will encourage more definitive time limit answers with less caveats, because it becomes something where, oh, if I say 6 months, they get access to a service. If I am a bit vaguer and say I don't know. But while the bill's use of 6 months prognosis assessed reasonably by doctors implies there's a simple calculation that can supply estimated life expectancy, as we've previously discussed, prognosis is not an exact science. And my concern, which follows on from the discussion we had last week about the power imbalance between doctors and patients and the deference shown to medical experts by many people sitting in that doctor's surgery or in the hospital, is that when a doctor says, when a patient hears a doctor say 6 months, they may assume that that's an absolute scientific certainty. The fact that there's a vast range of possible trajectories is something that I think the patient won't work out unless they're explicitly told it, which is why I like these amendments. This is just about ensuring that patients have a chance to understand how widely varying their future might be, that clinical predictions of life expectancy show wide variability depending on the condition that they have or the method that's being used to calculate it. For example, just a couple of examples, I think it's important that female patients are told that women with terminal cancer tend to survive longer than men, yet prognosis are rarely disaggregated by sex. But, you know, tell women, that'd cheer you up. Maybe don't tell the men. Patients need to know that prognosis is also likely to be especially wrong with poorly researched conditions like cancer in younger adults or MND. I mean, it's shocking to me to discover that in Canada, most people with MND now die by assisted death. I mean, that's such a shock. But anyway, yet the natural progression of the disease is very hard to predict. And yet people actually are given assisted death as a terminal illness for MND. And yet, how would you know when, in fact, we're only finding out and people can live years longer than the doctors had originally thought? One key point is that modern treatments and medical breakthroughs can also make forecasting with accuracy more hazardous. There's a lot of cystic fibrosis in my family. Those close relatives doomed as having this life-limiting condition have survived wonderfully, have survived far longer than anyone thought they were going to, because they were told that they wouldn't survive. But they've survived because new drugs and treatment have had miracle impacts on life expectancy. Isn't that something to celebrate? But nobody thought that was true. I mean, we just thought they wouldn't make it. Or look at the miraculous efficacy of immunotherapy in terms of taking on stage 4 cancer, as described by the Noble Lord, as evidenced by the Noble Lord, Lord Moylan. Then there's some patients who will undergo treatment given actually as part of palliative care. It's administered to somebody with a terminal illness with the intention of improving quality of life, no expectation of cure, probably on the basis, oh, well, you've got about 6 months to live. The patient is still terminally ill, but some patients, and we'll all know people like this, respond much better than expected and have both the length and quality of their lives extended beyond expectation. And that's a precious bonus. And I just think that patients should be told those possibilities when they go in, because otherwise they might despair. At the very least, patients need to know that this sort of granular detail, that there are possibilities rather than a stone cold, you've got 6 months, you immediately think of all the worst things that can happen and maybe therefore make a decision that is quite literally fatal. This is not, by the way, about selling false hope. Some may die naturally before the 6-month red line. Others may not, and they need to know that. Or the consequences could, as I say, be unnecessary and bring about premature death based on despair or false information. Oncologist Professor Chris Parker from the Royal Marsden points out that, quote, "I have little doubt that some patients would choose assisted suicide if it was legal because they were told they had less than 6 months to live. But in truth, if they had not had assisted suicide, they could or would have lived for years and enjoyed a good quality of life, because I've seen patients like that. We just shouldn't allow this bill's 6-month prognosis to become effectively an early death sentence because patients don't know the odds aren't definitive and because they're actually sold misinformation by saying you've got 6 months to live when it's a bit more complicated than that."